Oh. I guess we need to turn
All right,
this
I'll
on.
invite everyone to return to their seats. I still see lots of empty seats right here front and center, so I'm going to keep badgering folks to move into these. If you want to be my friend, move into the front seats. All right, so we're going to kick it off now with our first of 4 panel discussions. I'd like to introduce Yan Yu, who's Associate Director of Regulatory Affairs for the National Center for Emerging and Zoonotic Infectious Diseases at the CDC, and she'll be moderating this first panel.
Is it better? Perhaps I should hold it. Okay. After the break for this first panel, we'd like to thank the panelists for their participation, and we look forward to dynamic live provider discussion. So the informational charge has sort of instructed us. And I want to, I guess, maybe start off because, as mentioned in the informational background that was provided in the earlier session, we have a lot of diversity in the audience as well as in our panelists that reflect local, regional, federal, governmental, non-governmental, academia, and pharmaceutical industry perspectives. So I wanted to ask, following the foundational information that was presented in the context of medical countermeasure evaluation, weaving through the primary source data sources that were presented in the glossary sections, to get your reactions and perspective from your respective areas of expertise, and drawing upon any present or prior preparedness and emergency response experiences in the ways that you could see contributing to the data collection efforts, since it is something that would entail coordination, intentional cooperation, and integration to make that collection to evaluate medical countermeasures like emergencies a success. So I would like to start with the panelists maybe with Allison. And maybe as we start, maybe you could give a quick background on your current role.
My name's Alison Levy. I am the Emergency Operations Manager with the local health department in Seattle, Washington. Pleased to be here. Our role is in carrying out the local response and making sure that the measures that are being implemented meet the needs of our local population. And so when we talk about the comments this morning, we're, of course, very focused on equity in our local community, and we will be asking questions such as, who may not be represented in the data sets that you're looking at. But we primarily need information at the local level to tell us more about the incident that occurred, what sorts of medical interventions may be available, not just for prophylaxis, but also for treatment. What is available in the supply chain that will greatly influence the response measures that we implement, and what is known about the effectiveness of the measures being used.
Hi, I'm Terry. I'm a family medicine doc, but I work in an ER. I work at Regenstrief right now, but I'm the former CIO for Indian Health Service and the CMIO for the VA. And I was active duty for 27 years, public health service, and did lots of response. So I'm going to talk a little bit about where I think we are now, and then I'm going to just share a pretty fast example with you of where we could be if we maybe had the F word and then did some other things too. So I just want to share an ER example with you. I still work in an ER because I think that last mile, that sense of what's beyond the last mile, is really important. And this is where you see EHR data sets. So over the weekend, I did 3 ER shifts. I only do 3 a month. I just happened to back-to-back them. And I saw somebody the first day, and then I saw him the third day. And the first day I saw this person, and he came in with what was an infectious disease, and I couldn't figure out what he had. And I was really worried, and some of this I think is because I'm trained in public health, and I was like, whoa, maybe you have something really weird, and I really need to worry about it, and I did all the tests I could think of, and I called infectious disease, and I let him go, and then 2 days later he came back, and he ended up being admitted to the hospital. But I think what's important to note is that we're all, as patients, providers, healthcare responders, public health, we're all dealing with those N's of one, and that N of one is what's really, really important. And the data that I collected there was lab data, and I love what Dr. Pratt said earlier. There was lab data. I'm sure there's billing data, because I'm sure I spent a lot of money. But in addition, what there is a huge narrative that nobody else is going to know, that I asked him a zillion different questions trying to figure out what was wrong with him. And that's a pretty typical scenario, I think, at the point of care that we all need to realize in terms of the initial identification, kind of that early part of the public health and the medical countermeasure response is that early recognition. I want to share with you, though, something we did during H1N1, because we've been talking a lot about it with Indian Health, because it goes to data. Indian Health Service, it's, if you saw that map of where the critical care network wasn't, that's Indian country. A lot of that, the northern tier plain states, 36 states have Indian Health Service facilities in them, run through the Indian Health Service and tribes. But we run our own health IT system. They still run their own system. And during H1N1, within 5 days, we were able to figure out what data needed to be collected by working with CDC, and actually ended up working with FDA. To put together a module and released it 4 days later, with 401.5 million lives being monitored within 5 days. So this stuff can be done, but that data set was able to be done because we knew what data we needed. CDC helped guide us. We had epidemiology there. We had public health there. And we were able to show that the data that you need can be gotten at the point of care, obviously using different platforms, not just electronic health records, if you can figure out exactly what it is, do standards, and do terminology.
Hi, my name is Anita Patel. I'm with the National Center for Immunization and Respiratory Diseases with the Centers for Disease Control and Prevention. My role there is I'm a senior advisor and the lead for pandemic medical care and countermeasures. I've been at CDC for some time now and have had, I don't know if it's a benefit or a disadvantage to be part of multiple different responses, ranging from Katrina response to 2009 H1N1, Ebola, Zika as well, many of them that have been mentioned today. I think overall, from a data standpoint, on the federal end, we need data to make decisions across the board from the very early onset stages of a response right down to as a response progresses. Going back to Carmen's original slide, when you saw all the actions and activities that occurred at the very onset of the H1N1 response and how quickly and how fast the actions happened, we want to make decisions based on good data and good information that we have. Those very early stages are so critical for us to be able to mobilize, share information, and get everything that needs to get done. Part of just general activation for us from the federal end is mobilizing emergency operations centers to streamline coordination efforts and allow us to talk across agencies. There was a comment made earlier on how can we do this more effectively. I think from looking at responses from one to another, we tend to get better because we are exercised more and we are in these environments where we have to share information and information flows differently. Our data requirements and our needs will vary. Looking at it specifically for medical countermeasures, I think that's a completely different question, as there's multiple facets on when you're going to need data and information. One of the other big pieces at the onset of a response that we're always concerned about is what needs to happen from a regulatory and a policy standpoint. A lot of what happens at the local level is contingent on what the rules and regulations are. So whatever information we can gather very quickly at the early onset could influence declarations, determinations of emergencies, implementing things like the PrEP Act, which can help from a localized response level, and also regulatory mechanisms like emergency use authorization that have been mentioned as well. So data is a key component. I think the data needs change throughout a response. Having, from a preparedness standpoint, being clearer on what we need on the front end and what needs may progress and change over time would be good as well.
Okay.
Hey guys, my name is Paul Petersen. I am the director of the Emergency Preparedness Program with the Tennessee Department of Health. I've been in that role for 3 years. Prior to that, I was the Strategic National Stockpile Coordinator for 8 years. In kind of evaluating what I was going to talk about today, I have so much I could share with you, so it was a good exercise for me to really distill that down. Really, as far as data needs at the state level, at the state health department level, to make sure the balloon goes up, we have to respond. Some of the major things that we find time and time again, of course, is communications. Do we have the ability to communicate with the impacted population quickly? And identify the scope and scale of the event. Was the number of people impacted? And then also, are there resource needs, be it medical countermeasures or other types of products that are needed, that are gaps in that population? And that's really where we start our planning and our operation when we are in an event. I wanted to jump into a couple different examples for you to show you, how we put this infrastructure in place. And just, remind the audience that all these emergencies start locally. And so everything that we do, state level, federal level, has a huge impact on what happens locally as far as policy, data collection requests, all those kind of things. So we have to really be mindful of that, of the people that are doing the work at the local level. One of the first examples I wanted to share with you is September 2012. We had a nationwide fungal infection outbreak, and it wasn't necessarily getting the right product, it was getting the wrong product. So contaminated epidural steroids injections with, in total, 750 cases in the US, 64 deaths. And what that really showed us was we have to be able to work hand in hand with the healthcare community. So we were on a daily basis getting line lists of individuals that were exposed to these products. We assigned nurses at the public health level, assigned them to individual patients. We were tracking over 1,100 patients for a 3-month period of time, getting them to care, letting them know what symptoms they had to be able to look out for so they could get care rapidly. There was a lot of concerns, that this could mushroom into something much bigger, even than what it turned out to be. But just the impact that we were able to show by reducing mortality from a 31% to 4%, just by getting people into care, was huge. But the ability to monitor those individuals, to have seamless connectivity to EHRs at the healthcare facility level, we actually passed legislation in Tennessee to allow us to have that easier transmission of data back and forth, to follow up on patients. All of those things, kind of built and developed additional relationships for additional emergencies going forward. There's a lot of good lessons learned there, and a lot of things to take home as far as how are we actually going to collect the data. We have the ability at the state health department level to, develop databases on the fly. So we will do that, and I can share more about that as we go forward.
Hello, my name is Quazi. I'm from Pfizer. I'm a Senior Director of Epidemiology at the Worldwide Safety Strategy there. And as part of our work, we are always concerned with the benefit-risk balance of our products. So naturally, the medications or the NCMs that are used in a PEH setting, we will still want to know the balance of benefit and risk there. The problem is in a normal, usual drug approval setting, we have plenty of time to do that. And in a post-approval studies that may go for 5 years, we study patients and get very large set of information on both risks and safety and efficacy of the product. But the problem with a public health emergency setting is we don't have that time. So fortunately or unfortunately, I didn't have a chance to do anything in a public health emergency setting. But the key to success, in my opinion, is to plan for the unplanned and have predefined protocol, and for individual product or MCMs, we need to know what data we will need. So this is complicated even more in this setting because we are not going to run randomized clinical trial in that setting. We will have a generalized group of patients taking the drug, and with very, very few background data or background health information. So in terms of epidemiology, confounding is a huge headache there. So unless we are prepared with a predefined set of variables that needs to be collected, even in a smaller set of patients who are receiving the MCMs, we cannot tackle this question. So from an industry perspective, I would say that the best preparation is to prep for the unplanned and predefine or preempt study protocols, have some target sites or work group ready who will be able to readily jump into action and collect the data without hampering the actual administration of the MCMs. So set up a separate work group or task force or like a SWAT team for data collection only.
My name is Adam Wilcox. I'm at the University of Washington, where I'm the Chief Analytics Officer at UW Medicine. I've only been there, though, a little over a year. I've spent a lot of my career both at Columbia University, New York Presbyterian Hospital, and then at Intermountain Healthcare, where I've probably spent about 10 years in each place. So a lot of my examples are going to come from those areas in this. I represent the researcher perspective, and the first thought one might have when you think about the researcher perspective in terms of a response is, well, that's nice, and I'm sure you can be helpful in the post-mortem, but right now there's a lot, it's not really useful what you can do, and we don't need the people in the corner just, data collecting just for their own sake. However, I do think there's some important examples that I've seen where research can be effective in this. And so the first one I'll give is when I'm thinking about the H1N1 response. When I was working at Columbia, there was a researcher in our department, Raul Rabadon, who, as the information was coming out, was able to quickly assess, based on the data coming from the CDC, that actually the strain of the flu strain that was coming was actually different than it was initially reported. And so sometimes it helps in terms of research community to have different people where their role isn't necessarily on the response, but in observation to identify things. Another example I'll give around that at the University of Washington is in healthcare organizations, it seems that we're learning a lot about populations, and I appreciate what Allison mentioned initially, where she talked about what populations are and are not represented. And for a long time, populations in terms of research and healthcare delivery were focused on the population who happened to be coming in. And population health initiatives throughout the country have kind of been changing that focus to teach us that we actually need to focus on the population that's not coming in. And that's a different group, and we've had to change our data systems and our thinking about those data systems because of that. But regarding that, I think that there's an importance in, as you bring in this data and you try and link it in some way, understanding the appropriate methods, which are generally founded pretty well in research, to be able to know what's really going on. So, okay. It's the last guy is always the one who seems like he's talking too long. So, and I'll just go really quickly here. So we were looking at data that was evaluating how we were doing in managing depression, and I recognize that's a little different, but the story about the data is interesting. So we were really thrilled as we increased our data collection ability that we were able to see a greater level of remission based on PHQ-9 scores for depression, and it took me, and having seen something done like this before, and it's kind of a common problem that happens not just in looking at depression data, but in other conditions. While people were celebrating the effect of the care that we had, I was the one pointing out this doesn't represent remission, this just represents a better data collection of the people who are in remission. We haven't done anything different other than collecting data, so the first thing we're going to start to detect is actually what we weren't seeing before. It doesn't mean that we've done anything better other than collecting data. And I think that understanding those methods and those biases as you go through can be really important.
may evolve or vary at different levels and as the response evolves, as well as specific responses. But I think maybe go further on from the data perspective in order to determine the types of data that would be appropriate, including data sources that would be appropriate to answer the key questions that the parent. It doesn't work? Okay. Is this better? Okay. So to follow up on parents' presentation that talked about key questions. So from the response perspective and communities, and all of us are here because we are in one way or another interested or involved and participate in emergency preparedness and response. And so we are all stakeholders and partners in this. And the gamut of the spectrum of emergency preparedness and response covers many aspects. So if you could share from your perspective, distilling down to some specific key example questions that you need answers to, and thinking about the type of variables that you need values to in order to address those questions, that would be helpful for our continuing discussion for the next 2 days.
I will answer that in a moment. I also want to take an opportunity to emphasize that as local health, we are struggling to communicate with our residents in a rapidly evolving situation. So when you talk about the compressed timelines for drug research and bringing them to market, we need to simplify those messages down to a few key elements and deal with the challenge of changing today what we knew yesterday. So just as you were struggling sort of to balance getting the perfect data with getting data out quickly, we are also doing our own risk calculations in order to promote healthy behavior in the public. And when we consider all the ways in which people prefer to receive information and all the functional and access needs and language barriers, our messages need to be very simple and succinct. Some elements, we think about the decisions we need to make in a short-term and long-term context. In the short term, things that we need to know to influence our policy and decision-making is who was impacted? Is it a closed or open population? Are other cities affected? Do we know if it's an accidental or intentional exposure? And the cross-jurisdictional coordination is going to be key. We talk about how all incidents are local, but in my perspective, I think all incidents are regional, and if we're not working in close coordination with our partners in a shared media market, in a mobile population that crosses county boundaries every day for work in healthcare, we are going to confuse the public on the actions that they should take.
I think just to comment on what Allison just mentioned about public, I guess, perception as well as acceptance of their participatory role in contributing to the data collection that evaluates medical countermeasures, I think would follow in part your mention of messaging.
Yeah, Allison, those are really great points. I really think it's this whole concept of citizen scientists, or how we engage with the community and what data sets they have available to share with us. In some ways, there's 300 million people out there that are bearers of what could be the next public health epidemic if we can figure out how to engage, listen, and get that data in. I think from a specific response to the data set, and I'm going to take out the legal and the regulatory because I think that's really important and it impedes the data set. But
and there are other sessions that will be coming up that focusing on those aspects.
The thing we don't do well, in my opinion, is capture symptomatology. We actually capture diagnoses pretty well. We capture meds, we capture labs, we may even capture vitals. Symptomatology is an area where data is difficult to capture because my definition of a cough may be different than your definition of a cough, even though my definition of diabetes may also be different. But that early part, that how the person feels and their symptomatology response to an intervention and a countermeasure, I think is really important. So from that too, we also don't do a great job of ensuring that that post-treatment, post-intervention data gets captured in a systematic way that can then be aggregated and exported.
So I think from the federal standpoint, I want to shift to take a bit of an operational view to this. So when we look across all of the medical countermeasures that we have, there's a series of questions that comes up in every response with every product, and it starts with, do we have the right drugs, right? Do we have drugs that are effective or safe enough that we feel confident to put them out there? Then it goes to a question of, do we have supply? Now, if the product's commercially available, great, it's already out there. If it's not, it may need to be stockpiled, and part of the stockpiling decision is how effective is the medication and how safe it is. Once we have safe and effective products, or as close to safe and effective as we can get at that particular time, and we have supply, then we've got these regulatory considerations that apply to how we use these products. So can the product be used under emergency use authorization? Can it be used, does it need to be used under an IND protocol? Do we need to be careful in how we put it out? Can we actually exercise other regulatory discretions like mass dispensing orders and make the products available without traditional prescriptions? Once we have those factors, we can then create a distribution plan to support the use of the products as governed by the regulatory mechanism, as well as the information that we know about effectiveness and safety. So that operations plan on how the products get out there, this is like the key distribution piece of it all, right? Access. So how accessible do we make this product? It's going to be contingent and dependent on the other factors that are all impacted by safety and efficacy of the drug. So the more we know about the products from a safety and efficacy standpoint, the better we can design this overall systems approach to it all. And then getting back to Greg's point, there's this, where do we put these products factor, right? The access points. But there's this also, how do people go to get it? What's the level of triage? Once they actually get the products that we think they need, are they taking it? In a country where you've got 40 to 50% of all prescriptions that are out there for long-term use not being taken, the compliance factor and the adherence piece of it is a big part of the puzzle. And then moving one step further, the tracking components and how that information flows backwards. So in every single one of these steps, safety and efficacy plays a major role. Going back up to the distribution piece of it, we often talk about pills into people as quickly as possible, that anthrax scenario. So in that scenario, you've got 2 drugs that are already FDA approved on the market, that we know a lot of information about, that we plan on having mass dispensing orders in place so that prescriptions and individual clinical assessment won't be needed on these patients. And there's a confidence level that we can mass dispense and get product into people as quickly as possible. On the flip end, if you look at H1N1 experience and what happened with Peramivir, it's a product that we know very little about. We had some safety information, some efficacy data on the product. The regulatory mechanism of choice was emergency use authorization. First time we had products really put out there that were in the investigational spectrum out there. We had to change the way we distribute it. It had to be each individual clinician making a request to the federal government for product to come down, and there was an additional component to tracking of product. We weren't collecting safety and efficacy data. That wasn't the goal of the program. The goal was access. So again, it changed. It wasn't mass dispensing. It wasn't pills into people. So having the right safety and efficacy information influences all these different stages and all these different pieces of this operational puzzle of the system. The last piece of this is also the acceptance component. So going back to individuals, whether it's a practitioner or whether it's an individual patient, for them to understand that the drugs are needed, that they need to be taken, and how, if they do experience any side effects, how that information can flow back upward.
I wanted to talk to 3 points. One, Allison brought up was the risk communication side. To be really effective, we have to be able to get out in front of any emergency and let the population know what we have knowledge about and what we don't. And then also, second to that, we have to be able to give them action steps. Just giving them information with nothing that they can do about it makes people feel kind of like they're, they're lost. So we want to make sure that we have action steps to really gain the public trust, because we want adherence to be there. We want people to take the meds when we ask them to. And on the ethical side, looking at, if we have a countermeasure, it's in short supply, who gets it? So the prioritization process also has to be really transparent for the population. And the data that feeds that can at times not be there. So, I think H1N1, that we had prioritization in vaccine early on before it was widely available. Those kind of things are going to happen in the future. So we need to understand that crisis standards of care, who's getting what, and the populations with the greatest benefit. And then finally, trying to use some of the IT systems and resources that we already have available with syndromic surveillance and syndrome monitoring that we have at local healthcare facilities, being able to use that and leverage that to be able to help us with decision making. So I like the idea of, we need to focus more of our efforts on the data collection side, on the inpatient side, than on the outpatient side or in a pod where we don't have the infrastructure, resources, and those kind of things to collect it. We're going to see, the impact of the event on the inpatient side with admissions and those kind of things, and we can track those upticks over time, and we have tools for that.
Right. I just wanted to follow up on the great point that you just made, Paul, about medical countermeasure utilization in the context of prioritizing, as you mentioned, about H1N1 vaccine, that early surveillance information that identify risk groups, informing that medical countermeasure optimal use, if you will, prioritizing the uses. And I think that's one aspect of, as we talk about sort of holistic approach to medical countermeasure evaluation, would be that not only clinical or efficacy, but what are the key sort of variables, again, or data elements that needs to be collected for clinical endpoints? Are there data that can only be collected in time relation to actual disease onset or exposure? So as opposed to data that may be collected retrospectively, or are there prospective aspects that must be incorporated, which goes into sort of the prioritization of the CONUPs as we talk about and engage in the dialogue of how to go about building national capability. So I just wanted to sort of your comment trigger that point. So I just wanted to chime in.
I just want to make one comment really quickly. The reason why Indian Health Service got involved in H1N1 is because there was early data indicating that American Indian Alaskan natives that was CDC data died at a much higher rate of respiratory infections after they got infected to H1N1. So it was that demographic data that had been collected really early on that led to a change in the response.
Go ahead, Quazi.
I will build up on what Anita was saying about efficacy and safety of a product. So those are the crucial elements in assessment of the effectiveness of the whole NCM program. Now, depending on what product we are talking about, we may have a lot of prior knowledge on the efficacy and safety, and if we have that, that's good. But in many situations, there will be the product will be used in maybe in an previously unapproved indication or a situation in a pod or in a very less rigorously monitored setting. So in those situations, we will need to have information on the baseline conditions of the patients, symptoms of course, and also their prior medical conditions. So if we have access to electronic medical record, that's fine. If we can identify the patient and get their background information, that is fine. But I am doubtful that in an emergency situation, it will be readily available as a prospective manner. Later on, we can go back and get their medical charts and medical records. But on the spot, to get quick decisions, we need to collect some basic medical condition, medical information. And I alluded to this before. We are working in a non-clinical trial situation there, and confounding is a major issue there. So we want to tease out the effect of the drug itself from all other pre-existing conditions, as well as potentially other over-the-counter medications people will be taking in a crisis situation. So very basic demographic and biomedical information, as much as possible we can get from the patients on the spot. We have to focus on that, both in outpatient and inpatient setting.
So I thought Anita did a really good job of identifying the questions that you might want to use data to answer. I thought that was very helpful to do. I've personally managed databases with electronic health record data over across 3 states. I think it's probably upwards of 15 to 20 million patients total in terms of those different areas and what we're looking at, and I may be estimating high on that, but that's what we do with data. But I've had so many people over that time come to me with data requests, and the question would be, what data do you need? And the response, well, what data? I need all of it. And why can't you just give me all of the data? And I don't want to get into the point of you can't handle all of the data, but just because then you get in trouble with that. But I think the PCORI methodology report in 2013 probably expressed it best, because they had the chance to look at what are the problems when you have too much data. And they said problems occur when the questions are driven by the availability of data rather than what was really wanting to be known. And I'm not quoting that exactly, but I think the first part I got pretty verbatim. And so first of all, the first questions about data, I would say, are what data do you need? I was part of a, back then when it was called the Institute of Medicine, study group where we were working on identifying what data systems were needed for monitoring patients living with AIDS and HIV. And we had a representative coming from an organization where they had found an ability to share data across 3 organizations, and that was Kaiser and Mayo Clinic and Intermountain Healthcare, which you think that's pretty fascinating. They figured out how actually to share data across that. But what they had there really wasn't the data that we're necessarily needing, because you imagine, oh, that means you've got comprehensive data on these individuals, and it took me to point out, what do you really expect to have a single patient to have data across any of those? You're really just demonstrating the ability to exchange data, and do you have the same standards? And the person who was responding said, well, you know, you'd be surprised how many people may be coming from Minnesota and come to Disneyland and break their leg. And I first thought, that's really rare, and I don't know that Disney really likes you expressing that as a common occurrence. And it kind of felt like grasping for straws about, well, we have this data, let's figure out what we can use for it, which is different than how Anita pointed out. These are the data that these are the questions that we have. Now, what are the data that we can find to answer that? And that's such a more effective way to do that. The second question I would relate to is similar to what Theresa talked about, these citizen data scientists. I was and I'll express it in a way that makes it sound so long ago. In the early part of this century, I was sitting next to a physician in a meeting when it was a boring meeting, and so she was surfing the web, and out came that Vioxx had been recalled. And she was able to, with the tools that we had in the data system at Intermountain Healthcare, and you know, this is the early part of the century, and it seems like this is so powerful, she was able to query immediately all of her patients that were on Vioxx and actually build up a response for that. And I'm amazed that, you know, 15 years later, there's a lot of organizations that still don't have that capability to do that, and in some cases we've gone backwards. It is critical that the people who are most familiar with what the data are representing have the tools to be able to navigate it. And so one of the biggest capabilities we have in response is, what are the data that the people who are responding are seeing, and does it look correct to them, and how are they using it? And that's going to be critical. And then the last point I want to make is building on a point that both Anita and Quazi made regarding safety. And just because you don't, you know, when you're looking at indicators, and a really good example from the non-response area is when there was initial looking at medical errors. So we didn't have really good data on medical errors, and so those who had the worst data had the lowest error rate, which sounds like it's really good. And as you start to increase your ability to monitor that, the first thing that happens is you look bad because you're uncovering more errors. But in a situation like this where we're trying to track something, understanding what the rate should be is really critical. I think as a field in terms of safety and monitoring, we would have done a lot better if from the beginning someone could have said, we expect the number of, or the error rate to be about X. And until you can actually see that rate, you don't have a monitoring system in place that's strong enough to make improvement. And when we're doing detection, it will be very useful to be able to disseminate quickly. We expect your rate that you should be able to be identifying is about X. And if you're nowhere close to that, your problem isn't that you don't have a problem, your problem is you can't see it. And I think sending those variables, those levels of expectation about what problems you should be seeing, and disseminating those broadly are going to be really critical. So in answering what questions about key data and variables, first, what data do you really need based on the questions? Second, how can you get it to the people who would be using it best? And that the closer to the point of care you can get, the better. And then third, what's a good metric for am I looking at the right data? Am I hitting this correctly? Just some way to calibrate my own data collection and own observation from that.
One quick comment on Adam's point. So just having the data is not enough. We have to have the right person who is handling the data with the right capability of understanding or analyzing the data. So not only collection of the data is going to solve the problem, and rather than giving the data dump to somebody who is not aware of the nuances of the data, we can handle it more like this. What is your question? We know the data, whoever is holding the data, we can analyze that and give you the answer. So that can be the framework.
A data set that I haven't heard mentioned today that could get at the symptomology that Terry suggested would be helpful is 911 call dispatch records. That's something that we use locally to inform us in all kinds of incidents, whether it's a power outage, monitoring for carbon monoxide poisoning, or in Ebola who was calling in with influenza-like symptoms, so we could triage them before they ended up in the healthcare system.
The one other comment I would make too, and it's to, I think it was you who said plan for the unexpected. So I think what we've seen in health IT, where I've spent a lot of years, is that we haven't designed for the unexpected, and that's what we really need to do. And we can't go back 30 years, so we can only go forward, and we need to figure out what are some elemental health IT architectural designs that need to be developed and promulgated and put in whatever retrofit health IT system we're going to use, because we're going to have multiple, so that we can have a design that can be a sensing agent for us in some ways, can be our eyes and ears at the point of interaction, regardless what the platform is.
So on that point, I think that is an interesting opportunity where there can be some interesting investigation, because when I think about big data, and Sue Bakken talked about big data earlier, my initial response when I think about big data is there's a lot of hype around it. But I do think there is an opportunity to identify change. You know, there's consistency that we can measure, and if we have a lot of data, we can start to see where the data start to change a little bit. And where we can see change is going to be very useful. And I think that opportunity to be able to see where there's some form of, some ability to monitor the data flows and where the data are changing in some way, in an unexpected way, that's probably going to be the most useful, other than getting the data to answer the questions. But if I think about a delighter of, oh, we never imagined we were going to see it changing in that way, those type of computational, using lots of data, high computation monitoring could be really, really valuable.
So just to, I don't know if this is a question or a comment, but when Suzanne put that slide up there with all of the big data, That's a lot of data. So I'm not a data person, and I look at that slide and I think, goodness, there is all of this information already out there. How do we streamline to pull the information needs across any of these? What's the interoperability between some of these tools? What's the innovative way of looking at some of this data? So if you look at some of the things that Boston Children's is doing, so John Brownseed's group there, they're mining information and data from Yelp, and what they found was 12% of all Yelp reviews are actually about food illness. So it's an interesting correlation. Like, what else can we do with the existing data that can help us mine for information? Is that level of data going to be good enough to meet the needs to inform response actions? But as the response needs change, so the comment here about the changing needs and to plan for the unexpected, we may not know what we're asking for, but if we understood the data sources a little bit better, and who has what types of data and what the capability of some of these systems are, what the interoperability are, that might be a good starting point. Again, I'm not a data person, but for those that are, like, what can this data possibly do for us? Because I don't think we're looking to create any new streams, right? There's a lot already out there.
For that would be the Sentinel initiative. So people are working, getting together the data from multiple different sources and pre-designing programming for rapid queries. So if there is a question, they can quickly run the query in multiple data sets at the same time and get the pooled information for you pretty quickly.
I think the other piece of this is also technology. So has anyone been to Disney lately? Like Disney World? I know we mentioned Disneyland already, but Disney World. So I was there with my kids a couple weeks ago, and I was totally amazed. So the wristband that they give you, so if you stay on a Disney resort, if you're connected, or even if you don't stay on a resort, you're connected with this wristband. This wristband has all of your information in it. So it's meant as a user for it to be something that's super convenient for me. I've got my credit card on there. I don't need to carry cash. I don't need to carry wallets. I don't need to carry IDs, nothing. So I walk around Disney with this wristband, and I'm swiping. I'm swiping to buy things for the kids. I'm swiping to buy food, and Disney's collecting data. Like, I was so amazed. I had this like data geek moment, even though I'm not a data person, on the amount of level of information that Disney now has about me. So they can use this to navigate and for advertising and for own data purposes to make their operations better. Now think about it from a scale standpoint. We were talking, Paul and I were talking about this earlier at the break. The data streams and the way that we collect data and information on a day-to-day basis, it's small scale. So the biggest challenge during a response is scaling that up. Well, Disney does this on the millions every day. So if anyone's here from Florida, you may want to talk with Disney to see if they can help with your emergency operations planning, because it's amazing. So what technologies can we use at a pod? Can we do something like that where you're just scanning in and out and you're collecting all this information? Not only that, you have a way to connect back to that individual too through devices like this. So some of this is also using existing technology in a different way that I don't think we've fully explored or thought through.
I think to follow up on the points that were made, to better understand the data sources as presented during the glossary section, but throughout the workshop, as we delve further into these interwoven discussions and a lot of the themes and caveats and the comments that were made, I think will resonate through the sessions. And so I just wanted to kind of mention this in what you noted as in the unstructured, structured big data, and as an example, to understand the utility of the data sources and type of data towards the type of questions that we need answers to. I think, Adam mentioned about defining the questions that we need answers to will help us to better pinpoint the type of data that we could pull from. I think the other, I guess it's bi-directional to understand the applicability and utility of those data sources to answer those questions, and are there real life examples, case examples or case studies that would help inform us in making, sort of thinking through those issues. And I guess on that note, as in whether there will be multiple sources of data that would be utilized in parallel, I'm sure, and staggered, and maybe one can be a trigger, and these can be sequential sort of events leading to different types of data collection, whether it be observational studies, patient registries, electronic health data, big data, clinical studies, or questions that could only be answered through traditional clinical studies or utilization of healthcare system to answer questions. And I think, Theresa, you had a comment that you wanted to make?
Well, let me respond to that, and then I did have a different comment. But I do think that the issue of timeliness becomes really critical here. So my comment is, I'm not sure we really do know everything we need to collect. And obviously the problem is always in retrospect, you realize, oh, there was an aha moment. If I had been looking for whether there were too many acorns on the Navajo reservation, I would have known there was going to be a hantaviral epidemic, but it was rodents. You know what I mean? So I just want to caution us that even though we have all that big data, we may be missing some data that we really need to be paying attention to, especially zoonotic data, because while it's there, I don't know if we get it. But in terms of how to use all these data streams for those different factors, and you talked about that kind of cascade of data, I think the issue becomes timing in some of those. So can you, I'm going to go back to this design, can you design the system itself, the data points, the way they're collected, the way they're aggregated, to be able to respond based on what the timing need is on all these. And I do want to make one other comment, and it's probably because Sue's in the audience too, and I know she's been talking a lot about health equity and health inequity, and I love the wristband idea at Disneyland, but most of the patients on the reservation wouldn't know what to do with that. So I just want to caution us once again that we don't want to intentionally create some kind of digital divide where people may not have had the experience to know how to use certain things. Go ahead.
So I think that there's two types of data, well, at least two types of data, but the first thing to learn is that data are not like people. Not all data are not created equally. And I think we need to understand that. But if we recognize that, then there may be ways that we can at least segment it and figure out which data can be used in what way. So when I think about it simply, if I were just divided into two groups, there's purposive data that we've collected for a purpose, and then there's available data that, because we happen to have systems that were collecting it, we were able to gather a lot of this. So the Disney World example is useful because that's one where the data were available. It was because they were doing it for some other purpose, but as they were doing it, look how much information they got from it. And when you have that data, that can be really useful in terms of identifying certain patterns. It can be really useful in identifying changes to those patterns. So you can detect something is different going on. But of importance, and you know, relating to how does that relate to the reservation, that's generally going to be biased data in some way. You're not collecting it on everyone. You're not following a rigorous methodology because it just happened to be, you could collect it because it was there and it was usually for some other purpose. Contrast that with data where you're collecting it for a purpose, where you're looking at it and it's being, you collected this data because it was, you knew beforehand that you needed it for some reason, and there's usually some methodology whereby you're collecting it. There's a challenge when we mix these. First of all is when we take data in electronic health records, and you think about the cost to collect data in electronic health records, that means that some clinician, frontline clinician, sometimes the doctor has to be recording that. And we don't want to make the doctor recording things at the same level that we're recording things at Disney World, because that's pretty expensive. So when we're having the doctor collect it, that's pretty purposive, and data lag discovery in that sense. And so that type of data is usually not very effective if we apply algorithms to it and try and discover something interesting that happened, because the data are being collected we didn't learn to collect that data until we knew that there was a reason. There are other opportunities, but that's the least biased. That's usually the most consistent, that's the most correct. But the other ones, we can identify patterns. And we do have challenges when we mix the way we analyze data with the different types. If we're using large pattern recognition algorithms on data that's collected for specific purposes, we usually don't discover much. And when we assume that the data that are really available are not biased, we discover the wrong things.
Thank you. I just want to be mindful of the time and want to invite Laura to join us for the facilitated discussion where you would also have a chance to further comment.